Hello, welcome to PICA's recent webinar Spotlighting Excellence in Patient Experience, which was recorded on the 26th of November 2024. We'd like to thank all our presenters for their time. We hope you enjoy watching this webinar.
Those of you who don't know me, my name is Chris Graham. I'm the Chief Executive here at PICA. My background is in measuring, understanding and improving people's experiences of care. I've been working in this field for, over 20 years, which ages me a little. But delighted that this year we've been able to join forces with the Patient Experience Network in order to host the Patient Experience Network, the PICA Patient Experience Network National Awards event. This year's event, I think, has been the biggest in PENA history. We had, I believe, around 350 attendees, which is tremendous. And had a day which I think was really, really filled with positivity, inspiration, and enthusiasm. We've had a lot of great feedback from attendees about how authentic the day was, about how inspiring it was, about how much they learned, and about the value of being able to interact with colleagues from different organisations around this shared agenda of improving patient experience and delivering the highest quality person-centred care for all, always. And we're really pleased to be able to provide some of the highlights from that today to give you some standouts. For those of you who weren't able to attend on the day, this should be really useful. For those of you who were, hopefully you'll see some things that you might have missed on the day by virtue of us being in two separate discussion streams throughout the day. I think that's that's almost all I want to say. I think I'll just add, we're really, really proud to be hosting this at PICA. Improving patient experience is central to everything that we do. We love PENA because it showcases good practice and gives really tangible evidence that we can really improve and transform the quality of care by focusing in on the experiences of our users. And I'm really, really proud that we're able to spotlight some of that today. But for a fuller introduction to PENA and to the event, I'm going to hand over now to Ruth. Ruth Evans is MBE, has been the managing director of PENA since its inception. Is now working with us as part of the PICA team. Ruth, over to you.
Thank you, Chris, and welcome everyone, and thank you so much for joining us today, and thank you, Chris, for that quick introduction. Yes, I am Ruth Evans. I am one of the founding directors of PEN, and I wanted to just give you a little bit of background to PEN before we and the awards before we start on the presentations, just so that you understand the context. I'm conscious that some of you may be very familiar with PEN, but some of you may not have been to the PEN Awards before at all. So we have had 1.5 decades of brilliance, not our brilliance, your brilliance. And what we've been doing through those decades is celebrating your best practice. I'm really conscious that not every organisation enters, but for those who are willing to put their head above the parapet and say, here, we think we've got something to share, this is what we have been celebrating over our 1.5 decades. So we have hundreds of examples of best practice. But today we're going to very much focus on the ones from last year. So you saw the award go flying by. That's what it's all about. But actually, it's about much more than that. And I thought I'd just share a few thoughts about PENA, the Patient Experience Network National Awards, or now the PICA Experience Network National Awards. See what I did there? It's very clever. So PENA, we are and are still the only national awards that were set up to recognise, share and celebrate best practice in delivering patient experience across healthcare. We're very proud to do that. And we were hearing only this morning why it's so important, because patient experience is at the heart of everything. Experience influences the outcomes. Experience influences how we feel about our work. And we know that safety and experience go hand in hand. We also, through our awards, want to put the spotlight on the work that you're doing. So what we have created or crafted through PENA is an opportunity to share the work and share it in a way that is exciting and energizing. And we're hoping through doing this, we recognise and inspire others as well. At the event, we have a day where we come together and we hear from all of our winners. All of the finalists showcase their best practice through posters, and we also have a book of best practice, or BOB. And this is something that we have on our website, so you can have a look through to see every shortlisted organisation a summary of their submission from last year. I'm holding it up for anyone who can still see me, but it is on our website, and Helen will pop that into the chat. And also, as part of sharing, our ambition is to create as many opportunities as possible to share, and this webinar is one of those. For those of you who have not submitted, or indeed for those of you who have, we have a range of categories. Each year we just revise them just to check that we're still current and relevant, and we're addressing the things that matter in patient experience. But broadly, they fall into these areas. So you can see that we have a series of categories that focus more on the big picture, the scene setting, the strategy, making sure that we've got an environment that we can deliver a great experience of the big picture. We have a category that's more around inclusion, how we're including and recognizing all of the different partners. Now, of course, inclusion of patients runs through all of the categories, but we have a category that specifically looks at that or focuses on that area, a sector. And then we have categories that fall into the journey. So as people are going through their experience along the journey, how are we communicating? What's the environment like? What's the role of tech? And how have we personalized it, for example? Obviously, we've got a section that focuses on outcomes and a series of categories in the outcomes. And then, because we can't do it without people, we also have one that recognises specific teams and individuals. So a sector that has a set of categories that focus on individuals and teams. And today we're going to be hearing from people from at least 3 of those sections. So with no further ado, I would like to hand over to Chris to introduce our first speaker.
Wonderful introduction. Thank you very much, Ruth. We have quite a few speakers to get through today, so 6 in total, covering different categories and building up to the overall winner. But we're going to start with Lisa Wheater from West Yorkshire and Harrogate Cancer Alliance. Lisa and the team entered the Cancer Experience of Care Award and won for their work called Remove the Doubt. Lisa, I'm going to hand over to you.
Thank you, Chris. Hi everyone, as Chris says, I'm Lisa Wheater at the Cancer Alliance, presenting today on Remove the Doubt. This is one of the resources that was this was one of the resources that was developed by the co-created workshop, so you can have a good look at that and how colourful and how resonating it is. So I've come today to present on Remove the Doubt, the award-winning Remove the Doubt now. Next slide, please. So the campaign was collaborated between ourselves and the UK's only leading LGBTQ+ charity, which we know as Outpatients. You may well have heard of them. They were called Live Through This. And we also did this with the marketing agency Mobas. So the aim was to increase cervical screening uptake across West Yorkshire. We particularly aimed this at Calderdale area, but we also had lots of resources available across West Yorkshire so that they could be used across board. So the awareness, it was to improve the awareness of signs and symptoms of cervical cancer, and it was particularly targeting the LGBTQ+ population ages 25 to 64, and that is the actual age range of people that are invited to attend cervical screening, people with a cervix. So this was the first time that we'd actually fully co-created the campaign. Of course, we have taken things to our patient panel at the Cancer Alliance, but this was a fully co-created campaign, and we worked with charities in Leeds area to identify people. And the workshops were attended by exploring the barriers and their experience of cervical screening, which allowed for a natural development of the campaign. So the group wanted particularly like a hints and tips element to be used as part of the campaign so that we could help with myth busting. So not only during the campaign, but for future use, it's there on the website, on the outpatients website, so we can refer to that and people can look at that as and when they come across the cervical screening. So luckily for the campaign development, we had lots of photogenic, brilliant people who that attended the workshops that really wanted to be, they were passionate about being included in the materials that we developed as well. And you can see that throughout the materials that we have developed. The next slide shows a short video explaining the campaign in a little more detail and some feedback that we received at the Calderdale Happy Valley Pride.
So all screening is important for everyone, and that includes cervical screening, especially for our community that has lower rates of it. So we need to get people out there and get them tested.
Our health isn't always prioritised in the way it should be, so we need to make sure that we're looking after ourselves as best we can and that we're not missing things because of the discomfort of going into a surgery and talking about these things.
I think it's a very straightforward screening, and I think it can be really overcomplicated, and I think a lot of it's just a lack of awareness and a lack of knowledge about cervical screening.
So there's some myths or misinformation about how screening works, so we just want to make sure the community is informed so they can feel like they're in control and go and get the screening that they're absolutely entitled to. So to develop the concept, we went with the community. We went straight to them and asked, what are your thoughts about screening and how can we address these to make sure you feel more confident? And then that's what got fed into the campaign, including the models themselves.
The campaign is absolutely fabulous. It's inclusive, it's eye-catching, it's sassy, and I just love just how diverse it is. The fact that, you know, all the publicity caters for the whole of the LGBT plus community, and I think that's what makes it so special.
So we're here to tell people about the campaign. So rather than just sticking it on the internet, we're bringing it to the people and we're going to let them know how important screening is for them too.
So maybe bring the practice, maybe speak to the nurse who's going to do it. If you're worried, you know, you can always arrange for an appointment beforehand, come and have a chat.
So my top tip would be just remember you're in control. Anything and everything that you want, do not want is completely up to you. You've got so many options, and if you want to stop, stop. Like, it's just all, the ball's in your court. So just remember that.
Thank you. Nice, colourful, happy music for a lovely lunchtime. So I'll talk a little bit about the creative concepts, and I know that Ellen attended the actual awards, and I'm not going to profess to know all about the the figures and stuff, so I'm doing my best. So the concept itself, it takes negative experiences, myths and misconceptions that are stopping people from booking the cervical screening, and it transforms this into a positive, empowering and authentic communication from those that are within the community to the community that it's aimed at. The structure physically removed the word doubt from the headline, hence the overarching campaign name, Remove the Doubt. The distinctive NHS lozenge that was in the top right-hand corner of all the materials, it doesn't overpower it, but it supports the campaign and gives it longevity as well. The pride colours are familiar to the LGBTQ plus community, and we've got different variations where the strap line above the heading is different colours, and it links in with the actual ambassador of that actual resource, because we've got a different person on each resource, or a group one. Next slide, please. So a little bit about the digital marketing, yeah. Sorry, I'm just getting my note. As part of the strategy from the insight of the co-creation workshop, we developed a pen portrait that included an overall media consumption and habits. So this was in terms of how to reach the audience, and that's beyond our initial conversations that we'd already had. Social media was identified as a key channel for the campaign for obvious reasons, but also we considered other channels too. So organic social media channels, yeah, sorry. So by this we mean that channels where connections are already formed, and in this case we refer to the outpatients channels due to its existing community connections and the use of the Cancer Alliance's pages as a validation tool, thinking not only about the patients that this was reaching, but also about our secondary audience of health professionals, and there's misconceptions along that as well. I don't know if this has been mentioned actually, but we did do some education sessions for health professionals alongside this, but I know in this presentation it's not mentioned, but that was another arm of it that we did. So in approximately just under 3 months, from 53 published posts, there were 7,400 impressions that gave a 4.7% engagement rate. Next slide, please. So with regards to paid social media, it was an addition. This is additional to the organic channels that we also looked at. For example, the paid channels such as Facebook and Instagram, targeting the capabilities. There are parameters in place that on these platforms to protect who we were targeting. In this case, we used things like interest, TV shows and public figures that we know were closely followed by the LGBTQ plus community to ensure of the reach. As you can see from the figures here, direct targeting increased the reach of our audience massively. So there was more impressions, there was a larger engagement rate. Although this is really good, there were some top performing ads, and they reached an outstanding achievement engagement rate of 11.67%. The industry average is around 5%, I believe. So again, I'm not an expert with that, but that's what I'm told. And click-through rate, so CTR we mentioned there is a click-through rate. So this is people that go to the website for more information. Next slide, please. So a little bit about out of home. So in addition to the 2 methods, we also delivered out of home advertising. So this is a wider opportunity for full impact of the campaign. Next slide, please. So we coupled this with the other 2 elements, and we included rail, roadside posters to increase the awareness. And this format also allows for more time for people to absorb the information that's in front of them. We position materials that were en routes to particular venues that we knew of, and we also did it on travel lines, and this was captured in the co-creation workshops as well. Next slide, please. So this is just a little bit more information about the Happy Valley Pride and the different resources that we had and the different places that we actually located the out of home stuff. So you can see there's quite a vast array of places that we did that. And I think that might be it from me. We have lots of resources. I've not listed all the resources. I think at the event there was a poster and there was lots of, so you could do a QR code, but we have got the resources and everything for people if anybody wishes to see them. Thank you.
Thank you, Lisa. Great presentation and really great work there. Some of the social media stuff, especially, very, very impressive. The reach that you've managed to get out of that, and the click-through rate as well, very, very impressive. So we'll be keen to hear more about that. We're going to take all of our questions at the end for all of our speakers. So if you have any questions that you'd like to ask Lisa, please do put them in the Q&A box, and we can keep an eye on them and then raise them later on. For now, to keep us to timetable, we're going to move straight on to our next presentation, which is Fiona Jenkins from Cheshire and Wirral Partnership NHS Foundation Trust. Cheshire and Wirral won the Measuring, Reporting and Acting Using Insight for Improvement category, and Fiona is going to talk about how they've used data to enhance person-centred care through expert-led collaboratives. Fiona, over to you.
Thank you very much, and thank you for inviting me this afternoon. So I'm Fiona Jenkins, Head of Experts by Experience for 3 LPCs, Lead Provider Collaboratives, Empowered, Level Up and Helix. I'll go into a little more detail in the next slide, please. Okay, thank you. So Cheshire and Wirral Partnership NHS Foundation Trust, known as CWP, is a lead provider for Empowered, which is adult eating disorder provider across the North West, Level Up, which is Cheshire and Merseyside footprint, young people and families, provider collaborative, tier 4 services. We've also just taken on Helix, which is a perinatal service, and the building will be ready the end of next summer, which is very exciting. So as Head of Experts by Experience, we put experts at the centre of core decision-making processes across the region, ensuring a consistent patient-centred approach is adopted by all NHS and independent sector providers in collaborative, reducing variations in care and driving innovation. You can see our partners from Empowered, from Level Up within the provider collaborative, and for the perinatal, it's CWP and Merseycare. So what I would say is that it's a real privilege to work for Experts by Experience, and they really do drive change. They're integral into the commissioning intentions. They're equal partners. They're on the clinical delivery group and partnership boards where decisions are made, and pioneering conversations and new models of care are discussed. So it's absolutely a privilege, and that they're phenomenal. So the LPC serve a population of approximately 7 million people. This is around Empowered and Level Up across the North West. Next slide, please. The collaborative brings together NHS providers that we commission, independent sector providers also, and the Experts by Experience together to focus on comprehensive data-informed care pathways, emphasising community treatment and minimising inpatient admissions. And I know Charlene's on the call today. She unfortunately left us a couple of months ago, and she was in charge of the data gathering, patient visits. We work as a team to ensure our patients are in the right place, the right time, receiving the right care. And she provided a fantastic dashboard to enable us with those updates, daily and weekly and monthly reports, which is really, really important into improving the care of our patients. Starting with the Experts by Experience programme, we meet for each of the LPC forums, we meet monthly, and we also have some face-to-face events as well. Extremely powerful to have the expert voice at the centre of everything. It really redefines your focus and makes a very clear picture about how we need to improve specialised mental health services. So like I say, experts are integral to everything that we do. The transformation approach to mental health services breaks down the barriers between care providers and harnessing the power of diverse stakeholders to deliver patient-centred care. So it's really important that our experts are at the heart of that, working as equal partners. Okay, next slide, please. Conscious of time, so I'm trying to whiz through because I have a habit of talking a lot. So with the help of experts, we facilitate transformation change through quality commission, focus on patient experience, clinical outcomes, delivering care closer to people's home. You know, that's what we want to get to. We look at prevention also. The performance is consistently benchmarked with all key projects delivering measurable outcomes. Additionally, performances is monitored by Experts by Experience, ensuring that this is embedded as a culture of co-production and user involvement. We continue to improve on the framework of services resonate with the actual needs and expectations of people we serve, rather than top-down prescriptive approach. And an example of this is when we're working with experts by experience to deliver training. You know, they are equal partners with our clinicians delivering trainings across the Northwest. Determination to achieve and address challenges often seen in mental health services, such as gatekeeping, inconsistencies, the mission criteria, service provision gaps. We need a diverse range of insights and experiences at the table to again improve the best outcome for our patients and families. The visions are differed from previous approach, sharing knowledge, skills and resources across the Northwest rather than working in silos. And that's so important because things are forever changing, aren't they? And with the insight of experts by experience, you know, that happens on a daily basis. So it's really, really important to work together and support each other and not work in silos. The creation of an organisation that's focused on care across the whole care pathway rather than solely community or inpatients, an emphasis on data-informed practice, and by placing experts at every level of the decision making, which is what we do, and it's working fantastically. Next slide, please. I'll just go over these quite quickly, really. Specialised mental health provider collaboratives were established in by NHSEI with a mandate for creativity and innovation driven through delegated commissioning. Collaborative partners spanning health and social care pathways are fundamental to achieving truly person-centred care. If you look at the partnership board, you know, social care, third sector organisations, carers organisations are on the partnership board. They also sit in the clinical delivery group where discussions on new model of care and support, and what's working, what's not working, stuck cases, you know, are discussed with our experts by experience on board as well. We want our young people, families and adults with experience of eating disorders to work alongside as equal partners in driving service change. Mentions about postcards from the future, that was some time ago, about a vision, you know, and it's really come on over the last couple of years, and I think we can tick quite a few of the boxes for people's visions of the future. It's not a soft option, it is a relentless focus on commissioning for quality, clinical outcomes, and most importantly, patient experience. And there's such a lot of work that goes into that, around supporting experts, around clinicians making time to have those conversations and take on board the learning. It's all part of the same thing. It's one big jigsaw puzzle in order to improve services. Next slide, please. Okay, some of our successes. So the empowered experts by experience have really, really grown in confidence, and they say it's part of the healing process, and they have been involved in training. We've trained over 1,000 professionals across primary care, specialised mental health, social care, social prescribers. We've been to mosques to meet asylum seekers and refugees. We've got over 200 third sector organisation contacts now. We're also part of a teaching partnership for Chester University, but it's 4 unis, 7 local authorities, where we know from the priorities of our experts, they want us to go out into the public and they want us to deliver eating disorder training to affect change long term. And that is exactly what we're doing with the support of our clinical team. Shared policies, so lead clinicians from across the Northwest support each other, as I said before, in the clinical delivery group, and outside of that, also through the website, through the newsletter, sharing documentations, new guidance, eating disorder events. You know, it's all about working together and impacting that change. Collaboration, increased collaboration allows people to be admitted to any Northwest SEDU within their local unit, and has a waiting list or particular expertise. For example, SEDU has particular expertise in caring for people that are comorbid, insulin dependent, diabetes. We work together to find the right place for that patient at the right time. So it's a real partnership working as part of the collaborative. Data sharing, eating disorder services across the pathway are more data informed. So the data sharing has significantly increased across the organisation. Again, that partnership working and sharing of good practice. Place-based reports, commissioners of eating disorders have developed place-based reports to share with community providers. This is informing regarding inpatient admission, helps to inform better community practice, and also that transition period when someone comes out of hospital or before they get to that point. So that's the empowered eating disorders. Next slide, please.
Sorry to rush you, Fiona, just a couple of minutes, please.
Okay, so Level Up, reducing unwarranted variation, again across Cheshire and Merseyside. Hear My Voice was around 5 films that if you look at the Level Up CWP website, there's the voice of young people who actually co-designed the film. They were part of the choosing the media company. They were involved in the filming and the sound, and it's around young people with learning disability and autism at crisis. What do they need us to know? There are 5 films. Please have a look at CWP Level Up website. It's all about de-escalation and how we need to change in the way that we communicate as a society to support our young people and adults. Training to receive, there are over 180 professionals trained throughout 23-24 around the Gateway process. The Gateway process is basically a fantastic initiative where it's a multi-agency approach. So if you have a young person that is kind of stuck, it's a multi-agency approach, social care, third sector organisations, health, specialised mental health services to find the right care for that young person. And Cora Cares, reduce admissions. Hopefully you'll have these slides later so you can have a little more in detail. And that's reducing inpatient admissions, and that's care again at home and within the community. And then community support is around assessments and outreach team, providing consultation for over 3,000 teams, service across Cheshire and Merseyside. Next slide, please. Okay, we'll go to the slide after actually. Thank you. So Dave Williamson is our comms manager, and he has worked really hard in creating a newsletter and website where everything is shared. So everything the experts by experience have shared in relation to the forum, priorities, model of care in the clinical delivery groups, information around transformation events and lived experience, a film, how it sounds to have an eating disorder. Everything we do is then put on the website and newsletter. So please have a look at CWP Empowered, and then again that will come up with the website. Thank you. I think there's one more slide possibly. Okay, I'll jump ahead. You'll have a look at that in the notes. And there's just a thank you to our experts by experience, that without them we could not do what we need to do. We wouldn't know where the barriers are, where the issues are, where the good practice is. Without their experience, you know, I wouldn't have a job. But you know, it's absolutely incredibly brave of them to share their lived experience and to be so engaging, to sit on a Teams call, to stand up in front of 70 people. So they are absolutely incredible, and I'm so proud to say that they're part of our commissioning team. Is that my 10 minutes?
It is, I'm afraid. Thank you very much, Fiona.
Thank you so much.
And thanks for showing your work. Great to see the impact that group of really committed people have had. So thank you. Again, if you have questions, please do stick them in the Q&A. There'll be an opportunity to ask questions for Fiona afterwards. Absolutely. We're going to move on right away now to Dr. Wendy Walker from the Royal Wolverhampton NHS Trust, who won the Making Complaints Count category this year. Wendy's going to be talking about care at the end of life and the learning that can be accessed from letters of formal complaint. Wendy, over to you.
Thank you. Good afternoon, everyone. If I could have the first slide, please. So in this project, what I'll aim to do is provide an overview of what we actually achieved in terms of process and outcomes, and how we analysed and learned from service user complaints concerning end-of-life care. And the next slide, please. So many of you will be familiar with this particular document, the NHS Complaints Standards, where it has been recognised that complaints are a valuable source of data, either through the analysis of issues raised in an individual complaint or by reviewing a cluster of complaints, so that we can actually organisationally identify problematic themes and trends in care. And so the methods that we use for analysis are really crucial to the quality of the feedback data, and this was a key goal within this particular project. And the next slide, please. So embedded in our project were three important elements for creative learning and problem solving. So the first, in terms of inspiration, we had this collective desire. We wanted to better understand complainants' concerns about care at the end of life. In terms of inventiveness, we wanted to create a dedicated tool to help uncover the system-wide problems in care. And then in terms of improvement, we wanted to work collaboratively with members of our here at the Trust, our end-of-life steering group, who were ideally placed to own the complainants' concerns, and they themselves could help drive that quality improvement. And the next slide, please. So we believe that the methods that we applied for this particular project may be applicable to a range of topics concerning complaints, but our particular interest was on care at the end of life. It's known nationally for variations in service provision and the standards of care. It's a recurring theme in the casework of the PHSO. And it's an area of practice that consequently has become very high on the UK policy agenda. It's a drive for reform that's underpinned by a national framework, and then we translate those national ambitions into local ambitions for care too. And the next slide. So moving on to the project design, it fulfilled the criteria of a service evaluation. It was involving the analysis of existing data in the form of formal complaints. And we undertook preliminary work, and the aim there was to develop an initial template of end-of-life care concerns. And that was followed by pilot work, which was to test the face validity of that template of concerns when it was used as a coding and categorising scheme. Our focus was on the pre and post-death information, and it was the care and support that was experienced by an adult patient and or their family, and this formed the criteria for including the formal complaint letters for analysis within the project. And the next slide. So this slide just gives a brief overview of the structure of HCAT, which was applied in this project. It involved coding and categorising concerns according to 3 domains and 7 related problem categories. The stage of care at which each problem occurred was also identified in accordance with the HCAT domains, and we used HCAT in conjunction with template analysis. And the next slide. So in terms of our outcomes from both the preliminary work and the pilot work, it informed the structure of a dedicated end-of-life care complaints analysis tool, and we have gone on to develop an accompanying toolkit. It comprises those HCAT domains and problem categories, and from our own analysis, we have a template of 25 originally derived end-of-life care concerns, which we call the subcategories, and together we have accompanying exemplar indicators that serve as a guide to the analyst, and many of those indicators have actually come from the actual words that were used by patients and families within those letters of complaint. And with regards to the stages of care, we actually replaced those with new descriptors, and that was really to enable us to identify the location of concerns that were external to the hospital setting. And the next slide, please. So this gives an example of the template from our actual tool. So in terms of the domain relationship problems and problem category of communication from HCAT, our specific subcategory concerns here were quality of communication and the unmet information needs. And there are some of the examples of those key words that I referred to with regards to exemplar indicators that can really help to guide and ensure that we have a more streamlined process to the analysis that can be time saving as well. And the next slide, please. So reducing the number of complaints and learning from them are key measures within our patient experience enabling strategy that we have in place here at the Trust. And I think we would say that through this project, we've realised several benefits and impacts. The tools and mechanism through which the standard of end-of-life care can be monitored, numerical data when it's presented in table and graph form can enable precise understanding, and the triangulation of complaint data with other separately analysed bereaved family feedback can strengthen the evidence presented at the table for improvement and change. And locally, it's our end-of-life steering group that comprises clinical, managerial and research staff they receive each report from the analysis, and they have embraced the data in order to improve end-of-life care. And the next slide. So this gives us an example of the usefulness of that data. In our 3-year complaint data set, communication problems dominated. We have 3 targeted interventions in progress. The development of a compassionate communication charter that's spearheaded by our patient experience team, a review of the daily interdisciplinary huddle to assess updates with the grieving family, and a quality improvement project to address the family members' identified need for accessible telephone inquiries. And the next slide. We do acknowledge, however, that this was a local service evaluation. It was within this one organisation. We can't guarantee that the patients and families in other hospitals will have the same care experience and the same range of concerns, but this is a tool that gives us a starting point, and we would like to carry out some further work. We'd like to determine the consistency, the accuracy and the user acceptability of both the tool and the toolkit in terms of its use in practice and its results. I think it's also important to note that our data that was the complaints that we utilised as the basis of this project, those letters of complaints came to us at the time of the COVID-19 pandemic. We can't guarantee that we'd have the same set of concerns always, but we have over time found stability in the concerns, and we've also done some small testing of those concerns in a comparable partner organisation, and I think that has given us the assurances that there is stability despite as we are now thankfully in that post COVID crisis and recovery period. And the next slide. So in conclusion, we advocate that this particular tool, it gives us a systematic approach to analysing and reporting complainants' experiences of end-of-life care, and it has
I think Wendy's just frozen. We'll give her a second to see if she falls out. Okay, so I think that may be a more significant technical issue. So I think we will move on. Wendy was coming to the end of her talk anyway, so I think we've got most of the key bits, but we can come back to her in the Q&A one. Hopefully she'll have been able to reconnect. Again, a reminder, please do drop your questions into that Q&A. That'll give us something to talk about once we hit that section of the agenda. But for now, we'll move on to our next presentation, which is from Nicola Wayne at Nutricia. Nutricia was successful this year in the Measuring, Reporting and Acting Using Insight for Improvement category for their work on patient podcasts called The Beat. Nicola, over to you, please.
Thanks, Chris, and thank you for inviting me to talk to everybody this afternoon. So as you say, I'm Nicola. I work for Nutricia, and we're delighted to be awarded winners in the measuring, reporting and acting category. So could you move on to the next slide, please? Thank you. So for those of you who have never heard of Nutricia or never heard of Nutricia Homeward, we are the UK's leading medical nutrition feed and service provider. We offer support to approximately 30,000 home tube fed patients across the UK, and we've been providing that support for over 25 years. So we arrange the monthly deliveries. Oh, sorry, can you go back to the previous slide? Thank you. So we arrange monthly deliveries of prescribed medical nutrition and equipment to patients' homes, and we support people to be discharged safely from hospital, and we also provide ongoing support to patients in their own homes 24/7, 365 days a year. So Nutricia Homeward, as I say, it's the service that provides that support to patients. And starting to tube feed can be really, really scary for a lot of patients. It often comes at the same time as a life-changing event or a diagnosis, or as part of a treatment for cancer, for example. Or it can also come as a decision that a family have made after a lot of time thinking about it, and maybe time struggling and managing, thinking more of children with neurodisabilities who their families make the decision after a number of years of struggling to have a tube fitted. So there's lots and lots of quite clinical and technical information at the start, and very little about how to live and how to manage with a feeding tube. And most people who have a tube have never met anybody else that's got a feeding tube that's been placed. And so one of the insights that we've had from our patients is that at the very start of tube feeding, especially, people are feeling very alone, very scared, very isolated. And when we think about eating and drinking, it's such a social event. It's so tied up with occasions and celebrations and time with friends and family. For some people, having that moment taken away from them or changing can be really, really life-changing. So that's kind of the context behind how we started off thinking about podcasts. So could you go to the next slide, please? So yeah, mentioned that tube feeding can be very daunting at the very, very start. So what we have within Nutricia Homeward, we have 160 nurses who provide support to our patients. And they're our frontline our interactions day to day with our tube feeding patients. And we have a system that we run, or it's not a system, it's a prize, a competition that we hold every year called Project Vision. And that's where our Homeward nurses can make suggestions for different ways of doing things, new initiatives, just different things that can really make a difference to their lives, the HCP's lives that they support, and also the patients' lives. And so podcasts actually came as an idea from one of our Homeward nurses through a patient who had suggested it. They wanted to know, how do they find out more information? How could they share this information with their friends and family as well? So we started off by doing a little bit of research. So we did some research into the popularity of podcasts, and you can see some of the data there. And I think one of the ones to really pull out from this is that podcasts have got a weekly reach of about 19% in the UK, peaking at around 27% amongst 25 to 34-year-olds. Now, 40% of our population are under the age of 18, so are being cared for by parents or guardians or family members. So part of our logic in deciding to progress with podcasts was the fact that we thought this would capture that parent, guardian, carer age range for our under 18 population. So next slide, please. So after doing a little bit of background desktop research, we then moved on to doing some patient research, because this was completely new to us. We're not podcast people, we're a medical nutrition company. So we asked some of our new patients, so our patients that had just started tube feeding, for some feedback. So we asked 26 new patients, we sent a survey out, and we had 26 responses. 38% of them were already podcast listeners, and 56% said, don't currently listen to podcasts, but I'd be interested in finding out more. And nearly 70% rated the idea as a positive, so 8 out of 10 or higher. We then conducted some qualitative interviews with patients. So we conducted 6 interviews, and all patients that we asked said, yeah, sounds great, would like to know more. And the key themes that they wanted was to know that they weren't alone and that there are others out there who tube feed, and just to help everything feel a little bit more normal, especially at the start. So we started planning, and then we have some patients who support us with a number of our initiatives. So we asked one of those patients and his wife to actually review the content and provided us with some really useful feedback. So that was great. And the popular topics, as I said, hearing from others, getting top tips, and finding out what to do when you're on holiday or when you go to school or work. So when you're not just sat at home, how do you tube feed when you're on the go? So that was some of the common ideas that we had. Next slide, please. So we launched 4 podcasts initially in March this year, and we launched 3 more in August. So the data that we ran at the end of September, we had just over 1,000 listens to podcasts, and we host the podcasts on all the popular platforms where you'd normally find a podcast, and we also host it on our website as well. So we can measure the number of people that have visited that page on the website as well. So we've had 473 clicks, and 20% of our visitors are returning visitors, which is really important because it means that they have listened to one episode and then come back to listen to a second or even a third. So that's really, really positive. Next slide, please. And this is some of the feedback that we've had from the people that have listened to the podcast. And I'll let you read it, but the one that the theme that really jumps out for me, and it goes back to that wanting to know that you're not alone, especially when you're starting to tube feed, is the fact that people have been tube feeding for a while, but then hadn't realised that some children would also be tube feeding, so they're an adult, or they have maybe got a child and then they've heard from an independent teenager who's managing herself now, and it gives hope for the future. So I think that's the bit that really resonated with me when I sort of was looking through the feedback, that it was meeting that need of people appreciating that they weren't on their own. And although it was scary, there were other people that were out there and there was lots of support, and people were managing and thriving on a feeding tube. Next slide, please. Okay, so in summary, it was quite a simple idea. It was proposed by a person who was living with a feeding tube. We really used those patient insights throughout to try and get the feedback to make sure that we were positioning this right. And it really played a crucial role to make sure that the content that we had was helpful and supportive and what people wanted to listen to. Hopefully we've demonstrated that podcasts are popular, they're quite easily accessible, and that patients really wanted to hear from others in a similar situation. What I would say is we recorded our podcasts over Zoom, so there was lots of ums and ahs and coughs and things like that, and that just made it more natural. It made it feel like it was more of a general conversation rather than something really, really scripted. And I think for me, the next steps with the podcast is how can we measure the impact of the podcast, not just the reach. So I think we've got a job to do still with extending the reach and making sure that it's available to those people who really want to access it. But also, how can we make sure that it's actually meeting people's needs? And I think as a business, we need to sort of take a little bit of a step back and have a little think about how do we do that. And the main thoughts really is through a survey and just to gather that patient insight into, okay, what do we do now going forward? But thank you very much.
Brilliant. Thank you, Nicola, and beautifully timed as well, I might say. Again, any questions for Nicola, please do drop those into the QA function, which you'll find at the top of the screen. We're going to move on now to our next presenter, Ollie Lodmore. Ollie is a member of the Paramedic Society at Liverpool John Moores University and is our student patient experience educator of tomorrow. Ollie, over to you, please.
Brilliant. Just checking you can hear me.
Yeah, we can.
Amazing. Thank you. So I'm Ollie, so I'm the president of the LGMU Paramedic Society, so Liverpool John Moores University. The Paramedic Society was originally founded in 2020, which was sort of COVID as we know it. And I think that was, speaking to the people who founded that, they made it so that they could enhance the educational experience. All the lectures were given over Teams and these sort of things. So how can you make that better? Currently, we've got 104 members. There's 140 students across all 3 cohorts. It's quite a high uptake, and actually this is the most members that we've ever had, and I think it comes based off the back of the successful year that we had last year. I think it's also important to note that a lot of our members aren't actually paramedics. We have people from the wider healthcare background. We have people who work for St. John and people who are interested in first aid and that sort of thing. So next slide, please. So I do a lot with the student body. I'm chair of the Student Council for the College of Paramedics, which are our professional body, as well as being a student representative both nationally and locally. But I think I started my healthcare journey with not wanting to work in healthcare. It was COVID. My mum's a senior nurse at one of the local hospitals, and she just wanted to get me sort of back onto a proper schedule. So I started volunteering in A&E. And that changed sort of the trajectory of what I was thinking of doing. But also the volunteering was really important to me. It gave me a massive chance to sort of give back to a hospital that has given so much to both my mum and me as well. I think it's really important that I do these student voice things because I think the student voice is so important. It is the future of healthcare. We are the future clinicians. It's really important that we're nurtured and we're empowered to be the best clinicians that we can be. And I think our society does that. The next slide, please. So across the UK, there's hundreds of academic societies, ranging from the medic societies who we're linked in with in Liverpool. You've got nursing, you've got OTs, you've got physios, and obviously paramedics as well, and everything else that you can think of. These are people who give up their free time alongside their studies. I'm doing this talk in between night shifts. I finished at 7. I'll start at 7 as well. I'm very much looking forward to getting back to bed. But you know, it's important. It allows for students to interact outside the traditional settings, the university classrooms, and offers a chance for students to enhance their knowledge. I think the social side of it's really important as well. Quite often we'll meet up and you'll find that students don't actually speak about university or they don't speak about placement, and that's massive from a wellbeing perspective and something that we found definitely beneficial over the 3 years that I've been at university. Next slide, please. So our society is 12 strong in terms of committee members. We have me as the president, and then Freya, who's currently sat on an ambulance outside hospital, as the vice president. We then have a treasurer who is Theo. He essentially just makes sure I don't spend all the money that we have. How our money is sort of, it comes about is we charge a membership fee, so it's £7.50 for the full year, and that's free access to things like the CPD events and the socials and those sort of things, as well as us arranging resources and creating things like that for people. It's been at £7.50 for the last 3 years. We've kept it there because we're happy with that. I think that's a price of an airport pint, and I think that's probably a good metric for people. Then we have 2 CPD officers, so we've got 1 year 2 student and 1 year 3 student, and they are our most powerful asset. They use a massive network, mainly through social media, things like LinkedIn, Twitter, and so on, and they'll reach out to people that the students want to come in and do talks. We're very lucky that a lot of people give up their time to come and speak to the student body, and we're so grateful for that. And we've adopted a cradle to grave mantra, which means that we teach everything from maternity, neonates, all the way up to end of life. And as part of that, we value service users' voices as well. So one of the most popular ones we hosted last year was from Carl Perry, a sudden cardiac arrest survivor who came and shared his experience. It's really important that we don't lose fact of that actually the work that we do when that person opens the door to us on their worst day of their life, we don't lose fact that they are a person, they're not just a patient. We then have socials. Now, socials is our biggest sort of team. We've got one person, Surma, who runs the sober socials, and that's essentially socials that don't drink. It's things like hikes, things like go-karting, paintballing, those sort of things. It's important as well that we understand that we are a diverse profession with a diverse student body, so it's important that we do that. We then have 4 people, so we've got 3 from year 2 and 1 from year 3 who help organise the big socials such as graduation balls, Christmas balls, those sort of things, as well as the in-between socials like Halloween. Fun fact, 2 people showed up to our Halloween social dressed as Ali G, so there we go. We then have charity and outreach, who are 2 strong, 1 year 2 student, 1 year 3 student, and they plan amazing charity events. Our most recent one being our 24-hour CPR marathon, which has helped us raise £3,600 for our local air ambulance charity, who we work very closely with. We've also just gone and supported them at their 2nd ever conference. And these are the opportunities that sort of come from students through our work. Part of that, we do outreach as well. Last week, we were in a school teaching them life-saving skills such as bleed control, how to perform CPR, and how to use a defibrillator. And most recently, our big push has been making sure that CPR training is equitable. There's a massive disparity. If you are a female, you are less likely to receive CPR. So we've also sort of petitioned and pushed the university to spend their money to buy female CPR mannequins and these sort of things to address disparities. Next slide, please. Last year's events, as I said, cradle to grave. So this is just a brief overview of what we've done. The CPD engages our students. It's exactly what the students want. We go at the start of the year and say, let me know, what sort of things you want to do, and we'll figure out how we can put it on, and we do, and I think that's very impressive. Socials, as I said, it's a great way for those students to engage outside the study settings. One of the big things is that students from level 4, 5 and 6 don't get that chance to sort of speak in the university, but it gives them a chance outside the university. And we've got a buddy system as well. It's not just first years asking the second and third years, everyone asks everyone questions. We've got loads of different group chats and things like that as well, and that's really important. Next slide, please. Our plans for this year. So we want to build on last year's successes. We've discussed a collaboration in partnership with our local fire and rescue service, who have an amazing training facility, as well as other local organisations, on how we can give the best to our students as well. And the main things are, it's really important that we balance theoretical and practical sessions. Charity, well, we had a target of raising £1,000 for charity. We've almost 4 times that currently. And our next big one will be going up Mount Snowdon with a mannequin. So one of the full weighted mannequins, and that'll be to raise money for TASC, who do amazing work in supporting the mental health of ambulance staff. As well as the social events, we've already hosted several, and we just sort of look to carrying that on. We've got a Christmas ball in a couple of weeks, which could be a nice way before people go home for Christmas. Next slide, please. So we want to create a dynamic, inclusive community which sets the standards for the excellence in paramedic practice, and we strive to inspire and empower our members through training, socials, wellbeing, fundraising and outreach. We also want you to empower people to be the best paramedics they can be and be the best students that they can be, because we all know at the moment it's a pressured system. It is awful to be a student at the moment as well, in terms of financials and pressures and these sort of things. And we hope that our society helps people in that way. And especially in the out of hospital environment, it's tough. We've got growing political pressures, we've got ambulance holding delays, and you also are attending some of the worst things imaginable. So if we can help students to keep their love for the profession via our society, I think we're doing something right. And the society has certainly kept me going throughout my 3 years on the course. Next slide, please. So thank you for listening, and I hope that you take my words and you can go away and figure out how you can do better as an organisation for students, and how you as a person can do better for students, but also get involved with local societies and try and help them. Thank you.
Thank you, Ollie, and thanks very much for joining us in the middle of 2 night shifts as well. Ruth, sorry, did you want to come in?
Apologies, I was actually applauding, but I put my hand up. But Ollie, I know Helen's already said it, but that's the first time we've heard you speak. Thank you.
So thank you. Obviously, role of paramedics is incredibly important, and we know from the NHS staff survey how pressured paramedics are. So I think that sort of mutual support is really, really important. Great to hear about it. I'm going to move on now to our final speaker, our overall winner from this year's Penna. Kate Tanton from University Hospitals Plymouth NHS Trust is going to be talking to us about their project, The Secret Garden. Sorry, not just Kate Tanton, also Diane Keeling. I'm sorry to miss you there. We'll be talking to us about The Secret Garden, fresh air space for everyone. Over to you.
Thank you. I'm just going to share my screen, so just bear with. There you go. Can you see that?
Yes.
Yeah,
there we go.
Lovely, thank you. Hello everyone, my name is Kate Tantham. I'm a specialist assistant in intensive care rehabilitation, and I'm here with a legend that is Diane Keeling, who's a neonatal nurse consultant. We're going to be talking to you about the Secret Garden space and telling you a little bit about the history of it, and then we're going to share with you some of the things that we do in our garden space. So how did the idea for our garden first come about? Well, it came about where all the best ideas come out in the NHS, which is with a patient story. So this is a man who was in our department 5 years ago who was working abroad when he sustained a high spinal cord injury. He describes himself as an outdoor person, and at that time we didn't have an outdoor space that we could get him out into easily for him to see his family and to see his beloved dogs. So we worked about coming up with a solution, and he helped us design that solution. His rehabilitation goal while he was in intensive care was to get to his daughter's graduation, and we're super proud that we were able to support him and his family to reach that goal. But while he was with us, clearly we kept him busy with his rehab, but it was very important for us and for him to be able to design a space that would meet his needs as a complex spinal injury patient, and to support him with his desire to access fresh air. So we started that journey back in 2018. And we're doing it because we know that patients really enjoy going out in the fresh air. There isn't any evidence base at the moment for supporting intensive care patients to prove the impact that fresh air spaces does. But we know from our other populations that fresh air space has a massive impact on patients' experience of being in hospital, their capacity to process their rehabilitation journey, supports mood and well-being, and supports increasing social interaction. And we see this with all of the work that we're doing. So we set about building this garden, identified the space in June of 2018. We opened first in Christmas Eve 2018, and then we started a fundraising project and opened formally back in 2022, and raising our money during COVID. So this is what the garden looked like in COVID. We were very lucky to be the first centre in the UK to support ventilated patients who were COVID positive to access fresh air spaces. And you can see from this image the challenges of getting intensive care patients outside into a fresh air space and the amount of staff that we need to be able to support that. So what do we use our garden for, and how has our garden changed? So our garden started off as a closed light well, and we've now created a bespoke intensive care bed space that has the capacity to provide oxygen, air, suction, power, Wi-Fi, lights, raised planting, vegetable patches, oxygen inside and out. So we've now got the capacity to care for for any patient, irrespective of how unwell they are and wherever they are across their trajectory of being in hospital. This is our garden in the summer. We are using our garden for staff events, for patient events, for rehabilitation, functional activity, supporting patients in reaching their family goals. So this is a lady whose goal it was to get out into the garden space with her grandson. And I'm really proud to say that there she is with her grandson on her birthday. Family reunions, celebratory events, rehabilitation, end-of-life care, and staff support. So we thought it would be useful if we shared some of our end-of-life care work with you. Also, clearly, Christmas is coming up, and I need to tell you that our Christmas lights have already on going up today, and we've got 5 therapy pony events coming up for our paediatric, for our adult, and for our long-term patients and staff. So what did we do? We built a garden, we designed a garden, we built a garden, and then we created national guidelines to be able to support taking patients outside. Because it's not good enough just to have a garden space for Plymouth. I want garden spaces and accessible garden spaces for everyone in the UK, irrespective of age, severity of illness and location. So what we thought we'd do now is we'll share some of our end-of-life case scenarios with you for our neonatal team.
Thank you very much. So we were a little bit late to the party because obviously this happened last year. So Kate's Journey and the Secret Garden has been over a few years. But hopefully what this picture does show is the complexity of taking out an ITU neonatal patient. And our adult colleagues certainly had a lot more experience by the time we got around to last year. So there was a real good collaboration with our adult ITU team for the very first time we took out the baby into the garden. They did a walkthrough, talk through with us, let us know everything we needed. But what was really important is the garden was already set up with the oxygen in the air. So I know at one stage when we were developing the garden, that was looked at as a possibility of not including to keep the cost down. And it was such a good idea to actually pursue that and make it fit for purpose, because that enabled us to take this baby out. Without it, there's absolutely no way we could do it. But we absolutely shared the experience from the adult team, and we did that walkthrough, talk through, and we were very open and honest with the families, and incredibly grateful to them for sharing the stories that they've allowed us to share here with you. The bed on the left, you can see mum's actually having skin to skin with the baby. That's why it's not an resuscitator. The mum and dad are there in the chair, just having some outdoor space, skin to skin. And as Kate says, in the absence of any evidence, to do these things is really difficult, and it is a mindset shift. So trying to say to our clinicians, you know, we want to take this baby outside, there's no evidence it's going to be of any benefit to them. But oh my God, the impact it's going to make on the patient. That's what we actually hope to achieve, and that's what we did achieve. And that quote at the bottom is from that family who was so grateful. And I think what we have to bear in mind is our neonates are often born in hospital. They are then transferred to a neonatal unit where we have artificial light, horrible sounds, smells of the unit, and those patients might never, certainly if they're in end-of-life care, as was Leo, see an outdoor space or have that ability to have outdoor time with their family. They had several hours outside actually before Leo went back into our neonatal unit, and then sadly died a few days later. This is Ruby's story. Ruby was the third child for this family, and the infants you can see there's actually her family. So what this absolutely captures is the fact that we not only have it for the mums and the babies, but also the extended family, like what they do with the adult care. And obviously having wrote a SOP from the first experience, this second one went really smoothly. They both did, but then this was particularly smooth because we're getting a little bit more experienced and then still having that support. And this was really special for Ruby's mum because again, it was that experience of having time outdoors with them, but particularly for her as a family, that the three children were actually being able to be together in an outdoor space, have the picnic together, and they had some the photographs that you can see being taken with a professional photographer. So absolutely memory making and capturing that event for them for future. And again, Ruby then, both families decided not to withdraw care in the garden, but came back to our neonatal unit having had that experience, which meant the world to them. That was just another picture of Ruby's journey outside, which really captured everybody in the team. And I think what you can see there is how many members of the team it takes to do that, which sometimes can feel overwhelming, but particularly for me, the important one is a student nurse. And I love the fact the student nurse is captured in this picture because we are hopefully setting the bar for her to say you can achieve so much when you put your mind to it to really improve patient experience. So we are proving it matters, and say we are trying to get the evidence going forward so that we can really get other units to engage and also to carry on doing it within our own unit. We presented a poster at Batham, so our abstract got extended there. We have done the SOP, which we are now using. And as I say, we are trying to capture as much parent experiences that they will share with us, which they've very willingly done, to take to other families and to share with our board. So what next? We really want to make it a possibility. This isn't about me coming or us coming here today to say, look what we've got, this is amazing. We are very much, look what we've got. We really need this for your patients because our feedback we've got from our patients is so special. And so we don't want this to be unique. We want this to be a possibility for everyone. We are collaborating with the neonatal bereavement services nationally and trying to get this as part of their palliative care as an option. It won't be for everybody. Not every family is going to want to do this, but it absolutely should be an option, like they would have in a hospice if they were to withdraw care there. We're creating a national voice for all patients, including the neonates and the families, about outdoor spaces within our organisation. And as we say, Kate, within the work that she's doing for the PhD, is about building that evidence base and trying to really capture these into an academic piece of work.
We were very proud. I'll let you go first. So we were really lucky, and thank you so much to everyone for giving us this amazing award. And here are some of our clinical teams in the garden holding the award and holding the prestigious piece of glass, which has done a tour of the hospital. Here's the neonatal team doing it as well. And so what are we doing now? What have we achieved since? Well, actually, we had lots of wonderful celebratory events. We've had some great press, which has really helped us in supporting bereavement services and our teams moving forward. We're clearly planning Christmas because that's a massive thing for us and for our patients. And we're doing lots of the evidence base and lots of the research to try and push this forward. I'm speaking with National Intensive Care and neonatal colleagues to how we can measure and support this moving forward. So I think our final thoughts are thank you, and we hope that we will continue to push forward this agenda. But it's a massive thing for all of us to be able to feel validated, I think, that we are doing good work and that it does make a difference and that our patients and loved ones feel that difference. And just to keep going and just to keep pushing. So if there's anything we can do to ever support you with accessing fresh air spaces for your patients, we would be really, really happy to. Thank you very much. Stop sharing.
Okay, Dan, thank you so much. That's a really, really excellent presentation. I didn't get to see it on the day, so I'm really glad to have caught it now. Very, very impressive. That absolutely textbook PENA entry and such wonderful impact for patients and families as well. Sorry, Emma Boxall, did you want to come in? Can we unmute Emma if she does want to come in?
So sorry, it was vigorous clapping.
No, not the first time. I'm sure it won't be the last, so don't worry about it. We're going to move on now and just take a few questions. We've got about 10 minutes left in this session. We've got some questions in the Q&A that we're going to go through for each of our speakers. If we don't get to your question, don't worry. We'll make sure we get that covered when we publish on the website. But I just want to pop a few questions to different speakers, and we'll start. Actually, I think if we can start with Wendy Walker, if you're here, because you got cut off in mid-flow and you didn't get the opportunity to tell us about the collaborative work that you're doing. I wonder if you could just say a little bit about that, please.
Yes, sincere apologies that, as technology goes, that I lost connection. So can I just clarify then, Chris, with regards to collaborative work, I think in terms of the question was, can I just clarify the question, please?
Yes, so I think it was your final slide where you didn't have the opportunity to cover it. I'm just pulling it up actually.
Yes.
So Ruth, this was actually a question from you in our Q&A. Do you want to say more?
Yeah, Wendy, just as you cut off, you said that you were working with another organisation as a comparison site, and I just was interested to know.
Yeah, we did.
Who and how was that going?
Yeah. So one of the key things that we acknowledged is that we actually received those letters of formal complaint that were the data set during the COVID pandemic. And whilst we acknowledge that those were concerns that relate to this one organisation, we thought it would be useful to collaborate with another partner organisation, another hospital, in order to analyse their complaints in end-of-life care to determine whether or not those concerns were comparable. And in fact, what we identified is that, yes, they were comparable and that was in the post-COVID period. So both from that data and also our own analysis over time, what we've found is quite a lot of stability in those 25 concerns. In fact, from the development of the original preliminary work, we only have 5 more additional concerns over a period of time. So I think for those on the call that may be interested in utilising this framework for their own analyses, I think the caution is that your concerns from your patients and families may be different. However, we found consistency over time. The other is that the other important thing, if I could just share an opportunity, is that there is a paper that we've now published, and that's now available post PENA. So that link is on the final, the last but one slide, and it's an open access paper. So if people wanted to find out more about the project and how to apply it within their own organisation, they may find that paper very useful. But yes, the collaborative work has been helpful, Ruth. Thank you.
Thank you, Wendy. I've just dropped a link to that paper into the chat for anyone who wants to access it.
Thank you very much. Thank you.
Really helpful to cover that point about comparability and stability, because that'll give people confidence in using the tool. Next question, I think if we can go to Lisa from West Yorkshire and Harrogate. We had a question from one of our guests in the chat about the outcomes and impact of the work you're doing. Specifically, did you see an uplift in cervical smear bookings as a result of the engagement?
Okay, yeah. So I think with campaigns, it's quite difficult to get an actual figure, and you can't really identify where that uptake sits. What we do know that is there's a national decline with cervical screening uptake across all age groups, and everybody with a cervix. It's been over 10 years now, so we are heading downwards. But in the area where we actually targeted, we did the Happy Valley Pride launch, and we've targeted a lot of resources out in Calderdale. We haven't seen as big a decline as what we have in other areas, so whether it's down to that or not, I'm not really sure. We can't say for sure. The Happy Valley Pride event is well attended by lots of people out of area as well, so I think it's about those key messages really more than anything about uptake. Even patients that are in the LGBTQ plus community, some practices possibly wouldn't even, practices wouldn't know who was in that community, so it's quite difficult really to tell. You're just kind of doing this with the campaign and hoping that it's reaching the right people, which we're getting asked for the resources quite a bit, so out across West Yorkshire, but also further afield across from other cancer alliances as well. So I think it's kind of a campaign that we just hope keeps giving, and the information that we've got there, so no definite figures as such.
Okay. Thanks, Lisa. It might be something that takes time to fully realise the impact. There's another question for you in the Q&A from Claire Turner. It's quite detailed, so I'd ask you to maybe take a look at that, and perhaps we can answer that offline.
Okay.
I'm going to move on to another one of our speakers now. If we can go to Fiona. We've had to hurry you through, I'm afraid, so you didn't get a chance to talk about the commissioning impact of experts by experience. I wonder if you'd like to say a word about that now.
I suppose I've got a bit of a different perspective really, because I'm not a clinician, so it's quite interesting to see the partnership working. So the impact on commissioning is, as I said before, the experts are integral. They are part of the commissioning team. So when we look at the commissioning intentions, it's integrated into priorities. So each forum's created their own priorities as experts by experience. Otherwise, it's just a talking shop, and we want a goal. We want our experts to see outcomes. So they've created their own priorities, and that's integrated into the team's commissioning intentions. And then the pathway process is, hopefully I'm answering your question, is part of communications pathway, which is that clinicians speak regularly to experts. We feed to the forum feeds back on the clinical delivery group or service improvement group, back to partnership board. And that's kind of how it works. So it's a continuous cycle of communication, new kind of initiatives, feedback, and that's kind of how it works. So it's kind of integrated. They're integrated into everything. Yeah. Hopefully that answers that question.
No, it does, and I think it makes a lot of sense, that deep integration and that continuous communication. So it's not a kind of an engagement that takes place and ends. It's more about building that relationship. I think that's really valuable.
Yeah, thank you. I just wanted to add as well, it isn't that we ask our experts by experience to just share their experience. They're all independent people with their own skills and contacts, and different experiences. So they are totally equal partners. When we ask them a subject matter, then we know that they will have a good input into that answer, without having to share their lived experience, because that's not always good for them. So hopefully that little bit more information on how it works.
Thank you. Ruth, you had a question in the Q&A for Ollie. I wonder if you wanted to cover that now.
Yeah, Ollie, I'm hoping you're still on the line. You made a very powerful call for support and for organisations to do more for their students. If you were to just pick one thing, what should organisations be doing?
Have students on your staff groups, so policy steering groups, things like this. Have students on them. MWAS as an organisation have only just we've done some massive work over the past 2 years. And now students sit on the staff groups and steer those policies. So I think it's important because policies affect us the same way that they affect staff, but traditionally we've been overlooked.
Perfect. So big shout out to the people on the group today. Have students on your staff groups. Thanks, Ollie.
I thought Ruth was putting you on the spot a little there, but it was a very, very clear answer and a very clear call for others. Fiona?
Yeah, just on from that, Ollie, we have some of our experts by experience of services that are student nurses and educational psychologists, and they sit in the forums. So that works really well, having your perspective as a student and also as an ex-service user patient. Thank you.
Thanks very much. Conscious of time, just going to take a couple more questions and then we'll move to wrap up. And Nicola, on your on the podcast, it's really, really great to hear about those. I just wondered about what kind of feedback you got from people since launching those. You mentioned a bit about the engagement and the number of listens you had. Has it opened many discussions with users?
Not as many as I would have hoped, if I'm honest. It's quite hard to find out. So obviously we have 30,000 patients. We've had 1,000 listens. And because we don't have the data of who's actually listened. So this is why I'm finding it quite hard to actually get almost the follow-up. So I was able to get some feedback from patients via our nurses, where our nurses had said, we've got these podcasts, they're great, have a listen. And we've been able to get some feedback that way. But I'm finding it quite hard to actually get feedback from the wider group because which is great. There's so many different places people can access them, and we wanted to make sure that they could access them easily. But obviously you can't then see who's accessed them and who hasn't, so it's a bit hard.
Okay.
What I would say is feedback from our healthcare professionals. So we recommend the podcast to our healthcare professionals to then recommend them to patients. So our dietitians, our nutrition nurses, and feedback from them has been really positive. So much so that they're saying, oh, can we have something that's every month or that's a regular update? But yeah, watch this space, I guess.
Yeah. There's a comment in the chat there from Ruth about the difficulty finding out who's engaged with podcasts, but I mean, it sounds like just based on that feedback from clinicians, there's a demand and an appetite for it. So very positive. Thank you. One last question for Kate and Diane. Your work is obviously built over a number of years. You've started from an individual experience and then researching the evidence base, and then spent time fundraising. I think people might look at that and feel like that's a lot and a big commitment. But you mentioned at the end that you're happy to support people who want to think about how they can get patients into open spaces. I wonder if you can perhaps say a bit more about that and about what your views are on the feasibility of that sort of work for others, because I think it's really inspiring and people will be excited to think about how they can apply those kind of strategies in their organisations.
I think my journey into building this garden happened because the patient told me I want to go outside. So I think hearing from your patients what they want you to include in their service is always the starting point for everything. And I'm really lucky, and we're really lucky, because actually the legacy of the garden means that we aren't on site often now when patients get taken out into the garden because the staff love it too. So I think whenever you are starting a journey in the NHS or in any healthcare environment, actually, the challenge is always the longevity and the longitudinal nature of getting stuff done can be quite challenging. So I think for me, the lessons are keep going, find cool people to play with to make sure you can get stuff across the line, listen to your patients and take your patients with you on the journey, because your patients will always be the thing that unlocks the problem. And we're happy to support anyone in any journey if we can.
Yeah, thank you. And that touches on a theme throughout all of these, actually. Collaboration and working in partnership is something that almost everyone covered in some way or another. There was that quote used from Helen Keller towards the end about how little we can do individually and how much we can do together. I think very, very powerful and a good rallying call for everyone working in patient experience. So thank you. And thanks again for sharing your excellent work. I'm going to pass over now to Ruth just to say a few final words in closing. Ruth.
Perfect. First of all, thank you everyone for joining us today, particularly to our speakers. It's just, I heard most already, but I didn't hear, because you never hear first time round, so it's always good to listen again. So please take the opportunity to go onto the website and listen if you feel that you've missed something, and share. Part of what we're here about is sharing. So I'm hoping you feel inspired by the speakers today. I certainly have been, and I will be re-energizing myself just from today. I hope you're inspired to go back to your teams and thank them, because they are doing amazing work every day, and what they do matters. And I'm hoping that you might have been inspired to take part. If you are, then have a look at the categories. They will be updated on our website in the new year, and we will be open for entries from about April. But students, we're probably going to open earlier, because we know that the timings don't quite work for students. And as we've all heard, our students are our future and make a tremendous difference. And you may feel that you want to just celebrate the good work a little bit more. And next year, we're going to be putting a big focus on Patient Experience Week, which is going to be the last week of April, from the 28th of April to the 2nd of May. So please watch our website for the things we're doing that maybe you can augment and take forward as you celebrate the brilliant things that are happening around your organisation. So probably enough from me, but thank you.
I wouldn't say much in addition to that, because I'm conscious we're over time already, but I want to say a big thank you to everyone for taking the time to be with us today, both to our excellent speakers. We've heard from some really, really great teams and individuals. I'm really grateful for you sharing your time and your stories and your experiences and knowledge with us, but also to all of our participants for your comments in the chat, for your questions in the Q&A, and just generally for your time. The purpose of doing this sort of webinar is to share and spread some of the best practice that we've observed through Penna. Really delighted to have the opportunity to do that and to have some great examples to show off. We really want to hear from you about your work as well. So if you've got projects that you think would be suitable for Penna next year, or that you think need to be elevated and spread and shared more widely, let us know. We'd love to hear about them. Similarly, if there's anything that you want to help us support with, do get in touch. You PICA, our full service research organisation. We are very, very happy to speak with you and help you with any queries that you might have. And finally, we will be sharing the slides the recording of this presentation via our website. Please do pass that on to colleagues who you might who you think might be interested, or who might not have had the time to be here today. We really want to have as much of an audience as possible to help elevate all of these great best practice examples. And I really will stop talking now, because I've comfortably exceeded my speaking allowance. Thank you again. Enjoy the rest of your afternoon, and do keep in touch. Thank you. Bye for now.